Hello everyone, and welcome to another stream of Advanced Pharmacology. Today we're talking about Chapter 18, Drugs for Alzheimer's Disease. This should be a relatively quick one. Drugs for Alzheimer's disease. Alzheimer's disease, or AD, is a devastating illness characterized by the progressive memory loss, impaired thinking, and neuropsychiatric symptoms, your hallucinations and delusions, and inability to perform routine tasks of daily living. More than 5 million older adults have advanced in Alzheimer's disease, in the sixth leading cause of death, with an annual cost of $226 billion. Major pathologic findings are the cerebral atrophy, degeneration of the cholinergic neurons, and the presence of neuritic plaques and neurofibrillary tangles, all of which begin to develop years before clinical symptoms begin to appear. This neuronal damage is irreversible, so Alzheimer's disease cannot be cured. Drugs in current use do little to relieve symptoms or prevent neuronal loss. Furthermore, for many patients, there is no significant delay in the progression of Alzheimer's disease or the cognitive decline. So it's pathophysiology. The underlying cause of AD, or Alzheimer's disease, is still unknown. Scientists have discovered important pieces of the AD puzzle, but still don't know how they fit together. It may well be that AD results from a combination of factors rather from a single cause. The degeneration of neurons. Neuronal degeneration occurs in the hippocampus early in AD, followed later by the degeneration of neurons in the cerebral cortex and subsequent decline in cerebral volume. The hippocampus serves an important role in memory. The cerebral cortex is central to speech, perception, reasoning, and other higher functions. As hippocampal neurons degenerate, short-term memory begins to fail. As cortical neurons degenerate, patients begin having difficulty with language. With advancing cortical degeneration, more severe symptoms begin to appear. These include complete loss of speech, loss of bladder and bowel control, and complete inability for self-care. AD eventually destroys enough brain function to eventually cause death. Reduced cholinergic transmission. In patients with advanced AD, levels of acetylcholine are 90% below normal. Loss of acetylcholine is significant for two reasons. First, acetylcholine is an important transmitter in the hippocampus and cerebral cortex, regions where the neuronal degeneration occur. Secondly, acetylcholine is critical to forming memories, and its decline has been linked with memory loss. However, cholinergic transmission is essentially normal in patients with mild AD. Therefore, the loss of cholinergic function cannot explain the cognitive deficits that occur early in the disease process. The beta-amyloid and neuritic plaques. Neuritic plaques, which form outside the neurons, are hallmarks of AD. These spherical bodies are composed of central core of beta-amyloid, a protein fragment, which is surrounded by the neuron remnants. Neuritic plaques are seen mainly in the hippocampus and cerebral cortex. In patients with AD, beta-amyloid is present in high levels and may contribute to the neuronal injury. Accumulation of beta-amyloid begins early in the disease process, perhaps 10 to 20 years before the first symptoms of AD appear. Because of the central role the beta-amyloid appears to play in AD, treatment directed against beta-amyloid are in development. So, the neurofibrillary tangles of tau. Like the neuritic plaques, neurofibrillary tangles are prominent features of AD. These tangles, which form inside the neurons, result when the orderly arrangement of microtubules becomes disrupted. The underlying cause is the production of the abnormal form of tau. a protein that, in healthy neurons, forms cross bridges between microtubules and thereby keeps their configuration stable. However, in patients with AD, tau twists in paired helical filaments that form tangles. So here, if you want to take a look at a picture version of what I just said, it gives you a better understanding of what that means. The apolipoprotein E4, apolipoprotein E, long known for its role in cholesterol transport, may also contribute to AD. ApoE has three forms, named ApoE2, ApoE3, and ApoE4. Only one form, ApoE4, is associated with AD. Genetic research has shown that individuals with one or two copies of the gene that codes for ApoE4 are at increased risk for AD. However, many people with AD don't have the gene for ApoE4. So, endoplasmic reticulum-associated binding proteins. The discovery of the endoplasmic reticulum-associated binding protein, or ERAB, adds another piece to the AD puzzle. ERAB is present in high concentrations in the brains of patients with AD. These high concentrations of ERAB enhance the neurotoxic effects of beta-amyloid. Homocysteine. Elevated plasma levels of homocysteine are again associated with an increased risk for AD. Fortunately, the risk can be easily reduced. Levels of homocysteine can be lowered by eating foods that are rich in folic acid and vitamin B6 and vitamin B12, or by taking dietary supplements that contain these compounds. Risk factors and symptoms. So, risk factors. The major known risk factors for AD is advancing age. In 90% of patients, the age of onset is 65 years of age. After age 65, the risk for AD increases exponentially, doubling every 10 years until the age of 85 to 90, after which the risk for getting AD levels off or starts to decline. The only other known risk factor is a family history of AD. Being female may be a risk factor. However, the higher incidence of AD in women may occur simply because women generally live longer than men. Other possible risk factors include head injury, low educational levels, and production of the ApoE4, high levels of homocysteine, low levels of folic acid, estrogen, progestin therapy, a sedentary lifestyle, and nicotine and cigarette smoking. So what are our symptoms? AD is a disease in which symptoms progressively relentlessly from mild to moderate to severe. Symptoms typically begin after the age again of 65, but may appear in people as young as 40. Early in the disease, patients begin to experience memory loss and confusion. They may be disoriented and get lost in familiar surroundings. Judgment becomes impaired and personality may change. As the disease progresses, patients have increasing difficulty with self-care. Between 70 and 90% of eventually develop behavior problems, such as wandering, pacing, agitation, or even screaming. Symptoms may intensify in the evening, a phenomenon known as sundowning. In the final stages of AD, the patient is unable to recognize close family members or communicate in any way. All sense of identity starts to get lost, and the individual is completely dependent on others for survival. The time of onset of symptoms to death may be 20 years or longer, but it is usually 4 to 8 years. Although there is no clear effective therapy for core symptoms, other symptoms, such as your incontinence, depression, can be treated. So, this following table here shows symptoms for Alzheimer's disease. It's a good spot to hit pause if you're unfamiliar. Drugs for cognitive impairment. Ideally, the goal for AD treatment is to improve symptoms and therefore reverse cognitive decline. Unfortunately, available drugs cannot do this. At best, drugs currently in use may slow the loss of memory and cognition and prolong independent function. However, for many patients, Even the modest goals are elusive. So here you see a pathway for how the treatment of Alzheimer's disease may be done. It's a good spot to hit pause to review the different pathways. Now see if I can bring it so that it's all in one section. So, 4 drugs are approved for treating AD. 3 of these drugs, donepezil, galantamine, and rivastigmine, are cholinesterase inhibitors. The 4th drug, memantine, blocks neuronal receptors for N-methyl-D aspartate. Treatment of dementia with these drugs can yield improvement that is statistically significant but clinically marginal. As one expert put it, benefits of these drugs are equivalent to losing half a pound after taking the weight loss drug for 6 months. Given the modest benefit of these drugs, evidence-based clinical guidelines do not recommend that all patients receive drug therapy. This decision is left to the patient, family, and prescriber. No single drug is more effective than the others, so selection should be based on tolerability, ease of use, and cost. Research has not established an optimal treatment duration. Properties of the cholinesterase inhibitors and memantine are shown on the following table. So here again is an excellent spot to hit pause so you can take a look at the drugs for cognitive impairment. Again, there is donepezil or Aricept, rivastigmine or Exelon, galantamine or Razidine, and memantine, also known as Namenda. Cholinesterase inhibitors. Cholinesterase inhibitors were the first drugs approved by the FDA to treat AD. 3 cholinesterase inhibitors are available. So, group properties, the mechanism of action. Cholinesterase inhibitors prevent the breakdown of acetylcholine by the acetylcholinesterase and thereby increase the availability of acetylcholine at the cholinergic synapses. In patients with AD, the result is enhanced transmission by the central cholinergic neuron that have not yet been destroyed. Cholinesterase inhibitors do not cure AD, and they do not stop the disease progression, although they may slow the progression by a few months. The therapeutic effect. All cholinesterase inhibitors are approved for patients with mild to moderate symptoms, and one agent, donepezil, is also approved for those with severe symptoms. Unfortunately, treatment only benefits 1 in 12 patients. Among those who do benefit, improvements are seen in the quality of life and cognitive function. However, these improvements are modest and short-lasting. There is no convincing evidence of marked improvement or significant delay of disease progression. Nonetheless, although improvements are neither universal, dramatic, or long-lasting, and although side effects are common, the benefits may still be worth the risk for some patients. So what are some of those risks? Adverse effects. By elevating acetylcholine in the periphery, all cholinesterase inhibitors can cause typical cholinergic side effects. So nausea, vomiting, dyspepsia, diarrhea can occur often. Dizziness and headaches are also common. The elevation of acetylcholine at synapses in the lungs can cause bronchoconstriction. Accordingly, cholinesterase inhibitors should be used with caution in patients who have asthma or COPD. Cardiovascular effects, although uncommon, have serious concern. The increased activation of cholinergic receptors in the heart can cause symptomatic bradycardia, leading to fainting, falls, fall-related fractures, and pacemaker replacement and placement. If a patient is experiencing bradycardia, fainting, or falls, and drug withdrawal may be indicated, especially if cognitive benefit is lacking. Drug interactions. Drugs that block cholinergic receptors, such as your anticholinergic agents, first-generation antihistamines, tricyclic antidepressants, conventional antipsychotics, can all reduce the therapeutic effect and should be avoided. Its dosage and duration of treatment. Dosage should be carefully titrated, and treatment should continue as long as clinically indicated. The highest dose produces the greatest benefit. but also the most intense side effect. Accordingly, dosage should be low initially and then gradually be increased to the highest tolerable amount. Treatment can continue indefinitely or until the side effect becomes intolerable or the benefit is lost. Properties of individual cholinesterase inhibitors. These drugs have not been directly compared with one another for efficacy. However, they appear to offer equivalent benefits. Accordingly, selection among them is based on side effects, ease of dosing, and of course, cost. Donepezil. Donepezil, or Aricept, is indicated for mild, moderate, or severe AD. The drug causes reversible inhibition of the ACHE, but is more selective for the form of ACHE found in the brain than found in the periphery. Like other cholinesterase inhibitors, donepezil does not affect the underlying disease process. Donepezil is well absorbed after an oral administration and undergoes the metabolism of the hepatic cytochrome P450 enzyme as CYP2D6 and a CYP3A4 substrate. Elimination is mainly in the urine and partly in the bile. Donepezil has a prolonged plasma half-life of 60 hours and therefore can be administered just once a day. Although donepezil is somewhat selective for brain cholinesterase, it can still cause peripheral cholinergic effects. Nausea and diarrhea are the most common. And like other drugs in this class, donepezil can cause bradycardia, fainting, falls, and fall-related fractures. To minimize side effects, patients are stabilized on the initial dosage for 1 to 3 months before an increase in the dosage is given. Rivastigmine. Rivastigmine, or Exelon, is approved for AD for the dementia of Parkinson's disease. Unlike donepezil, which causes reversible inhibition of ACHE, rivastigmine causes irreversible inhibition. As with other cholinesterase inhibitors, benefits in AD are modest. Rivastigmine is available in tablets and solution for oral dosing, and a patch for transdermal dosing. The oral rivastigmine is well absorbed from the gastrointestinal tract, especially in the presence of food. With the patch, blood levels are lower and steadier than with the oral therapy, which improves tolerance. The patch is also beneficial for patients who may have difficulty swallowing. Because 50% of the starting dose remains in the patch after 24 hours, it's essential to remove the old patch before a new one is applied to avoid toxicity. In contrast to the cholinesterase inhibitors, rivastigmine is converted to inactive metabolites by ACHE and not by cytochrome P450 enzymes in the liver. The half-life is short, only 1.5 hours, and it is eliminated in the urine. Similar to other cholinesterase inhibitors, rivastigmine can cause peripheral cholinergic side effects. These occur more frequently compared with the other drugs. With oral dosing, the most common cholinergic effects are nausea, vomiting, diarrhea, abdominal pain, and anorexia. Weight loss occurs in 18 to 26% of patients. By enhancing the cholinergic transmission, rivastigmine can intensify symptoms in patients with peptic ulcer disease, bradycardia, sick sinus syndrome, urinary obstruction, and lung disease, so caution is advised. Like other drugs in this class, rivastigmine can cause bradycardia, fainting, falls, and fall-related fractures. Blood levels are lower than transdermal dosing than with oral dosing, and therefore the intensity of the side effects are lower as well. Rivastigmine has no significant drug interactions, probably because it does not interact with hepatic drug metabolizing enzymes. Galantamine, or Razidine, is a reversible cholinesterase inhibitor indicated for mild to moderate AD. The drug is prepared by extraction from daffodil bulbs. In clinical trials, galantamine improved cognitive function, behavioral symptoms, quality of life, and the ability to perform ADLs. However, as with other cholinesterase inhibitors, the benefits were modest and short-lasting. Galantamine is rapidly and completely absorbed after oral administration. Protein binding in plasma is low. The elimination is by the CYP2D6 and CYP3A4 hepatic enzymes. Excretion is renal. Moderate to severe hepatic or renal impairment delays elimination and increases blood levels. Therefore, dosage should be decreased for patients with moderate hepatic or renal impairment and avoided with severe impairment. In the healthy adult, the half-life is about 7 hours. The most common adverse effect is nausea, vomiting, diarrhea, and anorexia, as well as weight loss. Nausea and other gastrointestinal complaints are greater than with donepezil, but less than with oral rivastigmine. By increasing the cholinergic stimulation in the heart, galantamine can cause bradycardia, fainting, falls, and fall-related fractures. Like other cholinesterase inhibitors, galantamine can cause bronchoconstriction and therefore must be used with caution in patients with asthma and COPD. Drugs that block cholinergic receptors can reduce the therapeutic effects and therefore should be avoided, which would be your anticholinergics, your first-generation antihistamines, your tricyclic antidepressants, and your conventional antipsychotics. Which leaves us with memantine, or Namenda, which is the first in its class of NMDA receptor antagonists. Unlike the cholinesterase inhibitors, which can be used for mild AD, Namenda is indicated for moderate or severe AD. We don't yet know if memantine or Namenda is more effective than the cholinesterase inhibitor, but we do know that it is better tolerated. Although Namenda helps treat symptoms of AD, there is no evidence that it modifies the underlying disease process. So, its therapeutic effects. In patients with moderate to severe AD, Namenda appears to confer modest benefit. For many patients, the drug can slow the decline in function, and in some cases, it may actually cause symptoms to improve. In one study, patients taking Namenda for 28 weeks scored higher on tests of cognitive function and day-to-day function than did those taking a placebo, suggesting that Namenda slowed functional decline. In another study, treatment with Namenda plus donepezil was compared with donepezil alone. The result, after 24 weeks, those taking the combination showed less decline in cognitive and day-to-day function than those taking donepezil alone, suggesting that either the two agents confer independently benefit or they act synergistically to enhance each other's effect. Of note, although Namenda can benefit patients with moderate to severe AD, it does not benefit patients with mild AD. So, how does it work? Memantine, or Namenda, modulates the effects of glutamate at NMDA receptors, which are believed to play a critical role in learning and memory. The NMDA receptor transmembrane protein with the central channel regulates the calcium entry into neurons. Binding of glutamate to the receptor promotes calcium influx. Under healthy conditions, an action potential releases a burst of glutamate into the synaptic space. Glutamate then binds with the NMDA receptor and displaces magnesium from the receptor channel, permitting calcium entry. Glutamate then quickly dissociates from the receptor, permitting magnesium to reblock the channel, and therefore prevents calcium influx. The brief period of calcium entry constitutes a signal in the learning and memory process. So if you want to see a picture version of what I just said, here is memantine's action. It's a good spot to hit pause just to kind of familiarize yourself. Under the pathologic conditions, there is a slow but steady leakage of glutamate from the presynaptic neuron and from the surrounding glia. As a result, the channel in the NMDA receptor is kept open, allowing excessive influx of calcium. High intracellular calcium has two effects: impaired learning and memory, and neurodegeneration. So how does Namenda help? It blocks calcium influx when extracellular glutamate is low, but permits calcium influx when extracellular glutamate is high, which is again shown in the following figure. When the glutamate level is low, Namenda is able to occupy the NMDA receptor channel and thereby block the steady entry of calcium. As a result, the level of intracellular calcium is able to normalize. Then, when a burst of glutamate is released in response to an action potential, the resulting high level of extracellular glutamate is able to displace memantine, or namenda, causing a brief period of calcium entry. Because the intracellular calcium is now low, normal signaling can occur. When glutamate diffuses away from the receptor, memantine reblocks the channel and therefore stops further calcium entry, despite continuing low levels of glutamate in the synapse. So, it's pharmacokinetics. Memantine is well absorbed after oral dosing, both in the presence and absence of food. Your plasma levels peak in 3 to 7 hours. The drug undergoes little metabolism and is excreted largely unchanged in the urine. The half-life is long, 60 to 80 hours. Clearance is reduced in patients with renal impairment. Adverse effects. Again, namenda or memantine is well tolerated. The most common side effect is dizziness, headache, confusion, and constipation. In the clinical trials, the incidence of effects was about the same as a patient who was taking a placebo. Drug interactions. In theory, combining memantine with another NMDA antagonist such as amantadine or ketamine could have an undesirable additive effect. Accordingly, such combinations should be used with caution. Sodium bicarbonate and other drugs with alkalinizing the urine can greatly decrease the renal excretion of memantine. The accumulation of the drug to toxic levels may also result. Drugs for neuropsychiatric symptoms. Neuropsychiatric symptoms, the agitation, aggression, delusions, and hallucinations, occur in more than 80% of people with AD. Although multiple drug classes, your antipsychotics, cholinesterase inhibitors, mood stabilizers, antidepressants, anxiolytics, NMDA receptor antagonists, have been tried as treatment, very few are effective, and even then the benefits are very limited. There's two convincing evidences that neuropsychiatric symptoms can be reduced with two atypical antipsychotics, risperidone or Risperdal and olanzapine or Zyprexa. However, the benefits are modest, and these drugs slightly increase the mortality, mainly from cardiovascular events and infection. Cholinesterase inhibitors may offer modest help. There is little or no evidence for a benefit from conventional antipsychotic, such as your haloperidol or Haldol or chlorpromazine, your mood stabilizers, your valproate, your carbamazepine, and lithium, antidepressants, or memantine. So, can we prevent Alzheimer's disease or delay the cognitive decline? In 2010, an expert panel released a report, Preventing Alzheimer's Disease and Cognitive Decline, which stated that we have no good evidence supporting the association of any modifiable factor, whether it's diet, exercise, social interaction, economic status, nutritional supplements, medications, or environmental toxins, that would reduce the risk of AD. However, this discouraging conclusion does not mean that all available interactions have been proved not to work. Rather, it means that the evidence is too meager to prove that some interventions might work. The following table here shows that the panel's conclusion regarding certain interventions, indicating the effects of the intervention and the quality of the research. So here is an excellent spot to hit pause before this chapter comes to its conclusion here. The interventions to delay the onset of Alzheimer's disease or slow cognitive decline. Again, it's a good spot here to take a look. Make sure you review it so that you have an idea of what works versus what may not really work, at least back in 2010. Again, this is an old report. It's now 2025, and some of the stuff is outdated. So please do keep that in mind. That, however, does conclude this chapter for the day. So I thank you as always for listening, and I'll see you at the next chapter. Till then, have a wonderful evening. Take care and goodbye.